My name is Kiran Pillai, and I'll be moderating today's open house discussion on the National Health Stack. I'd like to welcome you all to this session. This is going to be the first of several webinars. In fact, when the team was preparing for this, we felt that there is a lot of areas to be covered. And so this one will largely be for techies and will focus on primarily one portion of the health stack today. And then we are going to have the next session in about a week from now. I'll start with a short, quick intro to myself before I start introducing my co-panelists for today's discussion. My name is Kiran. I'm a telecom engineer by training. Co-founded a company back in the 2000s called OnMobile. The company, happily went public in 2008. From 2010 onwards, I've been very interested in trying to solve for and look at how larger ecosystems and problems can be solved. So briefly volunteered with the Aadhaar program for about 2 years. And about 8 years ago, I decided to become a practitioner in healthcare. So I started a chain of eye hospitals, mostly tier 2, tier 3 India. So we have hospitals in district capitals, taluka level towns, and models to kind of cover people in the villages. And found firsthand that some of India's hardest health problems can actually be supported by a strong digital foundation. And I think many of us have experienced firsthand what India Stack has managed to do for many sectors. Its principles of public goods coupled with private innovation actually has been a major game changer for many sectors in India. So today's discussion on the National Health Stack is built, or the thinking is on very similar principles. So I have been involved with the National Health Stack, since about 2017, and the work had already started, much before, I started to participate in many of these discussions. And we are happy to see that there has been strong interest from all kinds of stakeholders who are part of the ecosystem, public, private, government. Everyone seems to have shown an excellent interest in the National Health Stack. But creating an interoperable ecosystem in any sector is always a hard problem, and it does require all of us, all of the people here on this group to come together to actually work towards some common goals. So before we get too deep into the National Health Stack, so I should add that for the last 2 years, since about 2018, I've also been volunteering with the National Health Authority. The National Health Authority is the nodal organization which is responsible for the Ayushman Bharat PMJY program, which covers about 500 million people for about 5 lakhs of health insurance. So I've been supporting them on the technology stack that they use today. Like to bring the focus of the discussion back to the National Health Stack today. And before we get into the health stack, I'd like to invite Sharath to briefly give a background on iSPIRT and also the India Stack and how that has helped. So Sharath is, as many of you know, likes to call himself and still is a kernel engineer in his heart, I think, but is also being a core, not just a core volunteer, but the heartbeat for all volunteers who work with iSPIRT. So Sharath, over to you.
Thank you. Thank you, Kiran. I want to spend a few minutes giving an iSPIRT overview, India Stack overview, and then we'll get into the health stack. So before we start, a big thank you to all of you. I know you've made time on a Saturday morning to attend this, and we will try our best to make this a productive session for you so that your time is well spent. So our iSPIRT, many of you know iSPIRT. iSPIRT is a non-profit technology think tank, and it's powered by volunteers. We call ourselves No Greed, No Glory Volunteering. So our goal is genuinely, you can call it ecosystem building, but more strictly nation building. And we think any change that you want to bring about is a 20 to 30 year kind of a journey. Even simple changes, which is segregating your garbage, for it to become a societal change will take 20 years. And other changes, almost any other change that we're talking about is a journey in that time frame. And usually in societies which make this happen, they have institutions that take therefore a 20-year or 30-year view. You have institutions like think tanks which do that. iSPIRT is one of them. Another example of that would be malaria. You can define malaria as a 5-year journey or a 10-year journey or a 20-year journey. Bill and Melinda Gates Foundation, for example, when they came out and decided to focus on malaria, they described it as a 20-year journey. Universities do it, not so much in India, but certainly in the West. Our driverless cars, for example, are anchored. The Sutradhar for this over the last 22 years has been Carnegie Mellon University. And we know that closely because some of our core volunteers, Vivek Raghavan, who's also a volunteer hero, and Lalitesh are PhDs from CMU. And of course, research labs take this view. I had the privilege of working for Bell Labs, so I've seen it firsthand, but it's also true for government labs. In India, many of these institutions are weak, and we as iSPIRT feel the obligation to basically take a 20-year view. And this 20-year view then goes in the hands of people who usually take a 10-year view. These are policymakers. They take a long view, and for them, long is about 10 years. VCs do that with entrepreneurs. Sometimes, most of the time, the VC's view of the world is longer than that of the startup that they are funding. And then, of course, the players who make all this magic happen, and they're the most important people in some way, they are either incumbents and challengers. So they have two perspectives. Either they're very excited about change or they're fearful about change. And there's a need to carry both of them with you. So, and they usually have a time horizon of 3 years, 5 years, because they need things to break even in that kind of time frame. So we work with all these constituents, the 10-year planners and the 5-year doers. So that's really what iSPIRT is about. And we're focusing on many areas. Our goal as iSPIRT is to stay small. We are about 100 active volunteers at any time, and we generally cap it at that level. We don't have an aspiration to be 500,000 volunteers because for our system to work, staying within the Dunbar's limit is very important. And that's what we are doing right now. So our goal is to help other iSPIRTs come up. And therefore we give away what we do, including what our volunteer model is. Every 3 years, we write it in detail. Our volunteer handbook is on our blog. You can read it. Even the way we work, what is a mechanism, a playbook for building playgrounds is also shared very openly with people. And we have started writing it down, and some of it is on our blog as well. So that's a little bit about iSPIRT. I want to give you a fresh perspective on India Stack. I don't think there'll be anybody here who doesn't know India Stack. And the fact that it is now regarded as a significant kind of an innovation breakthrough in many parts of the world. I'm not going to go into that, but India Stack simply stated is a collection of building blocks. And those building blocks fall in 3 buckets. There is the identity layer, there is the payments layer, most of you know UPI, but there are other parts of the payment systems that are part of India Stack as well. And then most importantly, a newest bucket is to do with data empowerment, data democracy, and that is to do with the account aggregator system in the financial data world. Prior to that, we actually had tried out the same concept with DigiLocker. All of this is anchored around something called the electronic consent artifact. And this whole stuff, which is very new, is called DEPA, Data Empowerment and Protection Architecture. You can read more about it at indiastack.org/DEPA. So what the point is that this public infrastructure that comes up, these building blocks that come up, basically enable many other applications. And these applications are provided by mostly people in the private sector. You have lending, which is a very important one that we focused on, and we want to democratize credit in a very big way here in India. And so that takes me to another view of India Stack, which you may have seen, which is called the Rajini view. This slide with the blue background is probably our most commonly used slide when it comes to iSPIRT. And this lady in the middle is a street vendor. She's a real street vendor, but her real name is not Rajni. We changed her name and we call her Rajni. She's the persona for us. And we've been, in some sense, working for her since 2013. So I want to kind of describe that to you, if I may, is that we want her to be able to take a daily loan on the mobile phone, right? Take a loan of 400, 500 rupees in the morning, retire that loan in the evening, and that should happen on a mobile phone. She already does that, by the way. She does that with money lenders. The money lenders charge her at least 1% a year. In some cases, it's more, 2%. There are cases where it's even 4% and more. But minimum is 1%. So on an annualized basis, this is roughly about 300% a year. So it's very large, a very high fee that she pays. We want her to be brought into the formal system on the mobile phone. So if you go back in time, to make it happen, this is still about, by the way, 2 years away from actually coming to life. Where we have reached is, in our journey over the last so many years, 2013, we have reached a point where I think we can democratize credit for small businesses. Not yet for Rajni. We still remain focused on Rajni, and we'll get there 2 years from now. But we think we are now at a point where in the next 12 months, small businesses will be able to avail of cash flow lending at a scale that India has not seen before. We expect that it will be at least as big, if not bigger, than what microfinance has become in 20 years. So what happened in 20 years, we think will happen in a year, largely because of what's been built. The way to read this slide is that what you see on the inside, here on the inside, is the innermost circle is what Rajni has to do. And this is the Rajni circle. The middle circle is what private innovators have to do, market innovators have to do. And to help them do this complex things quickly in small teams to build complex stuff, they need public infrastructure, and this outer layer is the public infrastructure. So this is an architecture, innovation architecture, that we call as the Jugalbandi architecture. We want a Jugalbandi between public infrastructure, digital public infrastructure, and private innovation to solve India's hard problems. And we feel that that is the only way you can solve India's hard problems, not for India 1A, which is 30 million families, not even for India 1, which all of put together is 100 million families, but for India 2, which is the next 100 million families, and for India 3, which is the last 100 million families. India has roughly about 300 million families. So far, our startup ecosystem has focused only on the 30 million families. The most prosperous 30 million families of India, 120 million people. iSPIRT's mantra or focus is to bring market innovation in place for India 2 and India 3. And for that, we believe public infrastructure needs to come in place. And obviously, this takes a long time for it to happen. So if you take the Rajni example again, if we have to bring her into the formal system, in 2013, there was only paper KYC that was available. There was no eKYC. So eKYC had to come in. And now, of course, when Jio used eKYC, 160 million people in 160 days, they paid roughly it cost them roughly about 5 to 6 rupees per eKYC. Today, at scale, you can do eKYC at less than 2 rupees. Then once Rajni can get into the system, she still will need to sign a loan agreement every day. And because remember, she's taking only a daily loan. So we created eSign for her. eSign was created originally for Rajni. And however, now India is the largest user of eSign in the world. When eSign was launched, eSign is merely a standard. All authorized players, licensed players are private players. And when eSign was launched, the market forces were such that the e-signature used to cost 21 rupees. At volume, it is now less than 1 rupee. So eSign came up. And then she needed to store or needs to store her loan agreement somewhere. She doesn't know how to use Google Drive, OneDrive. So DigiLocker was created originally for Rajni. And of course, now it has, very large number of documents. I don't even remember the number. It runs into very large numbers. And then there was a need for her to receive the money in the morning and for her to send the money back in the evening. And for us to be able to do that, if you go back to 2013, 2014, even 2015, the only real way for her to do that was through the debit card. And the debit card was charging 1% on the way in and 1% on the way out. So we went to them and said, hey, this doesn't work. They said, okay, no, this is a very good use case. We'll do it for half the fee, and it'll cost 0.5% going in, 0.5% coming back, and it'll be 1%. And we thought, what's the point of taking 1% from an Indian moneylender and giving it to a foreign multinational? So that is how the genesis of UPI came about. And now you know UPI does more transactions than all the debit cards and all the credit cards in India put together. In fact, yesterday it did more transactions than what American Express did worldwide. And in about 2 years, we feel UPI will do more transactions in India than MasterCard will do worldwide. So, so that is how UPI came about. Now, if you have two Rajnis, you want the Rajni which pays on time to be able to get a cheaper loan than the one who doesn't pay on time. And how will that happen? That will only happen if she threatens to take her business to another NBFC or another bank, because they're not giving her the cheaper rate of interest. And so therefore she must have portability. She must have choice. And in this world, portability means data to be ported or data to be shifted. So sharing of data or with her consent became the focus of the account aggregator. So that's the fourth thing that came in place. And then we realized we must focus on SMEs. So we have reworked BBPS to suit that. There is something like e-lien and e-mandates that are coming. There are now APIs for loan service providers that are in place. And the last piece that will fall in place maybe next year, or hopefully next year, but may be early part of the following year, is the public credit registry. And once that falls in place, the Rajni use case will come to life. But in that journey of 8 things happening, all of the other 7 things have been generally successful. So this is the way we think of it, as a design use case, and then build stuff that will bring a very difficult use case to life over a period of time. So in this process, as we have gone through this process, of course, many market participants get involved. And once there are enough of them, they begin to form groups, of players. The market players come together to form groups, and they become trade bodies. And there are, in that space, there are 2 that have been formed. There is at least 1 more called Credol, which is in the works. So there'll be 3 that will be up and running. You can look them up. These are basically a collection of players. Now, when we get to the health stack, the whole thing is now happening in some similar fashion, and a very thoughtful collection of players that has already come together is called Swasth Alliance. Some of you must have heard, because this session is actually originally, it was the last 1 week initially prompted by the request from many of the Swasth Alliance members that we should do this series of talks for everybody. So this is what is happening right now. So this is a picture of India Stack. Now, what is the underlying bigger story here? The underlying bigger story is that as we move to this new way of innovating for India, what is this new way of innovating? The old way was, and you can see that in many cities of India, in the old way, you would have, a fancy building that emerges in the middle of basically, perhaps even kind of not carefully city planned surroundings. So there's a very narrow access road. And this building, for it to be viable, has to arrange for its own water, has to have its own electricity backup, because it can't rely on the public infrastructure to be there. And so therefore it has to be somewhat self-contained. It's a gated community. And so this has been our lived experience even for innovation in India. Our startups have to do everything because there is nothing to rely on. The Western startups are not like that. For example, if you think of Uber, Uber would not exist if there was no GPS. That's the public infrastructure that makes it possible. Google, is there because Gmail is there because SMTP is there as public infrastructure. So in their lived experiences, that the public infrastructure comes first and private innovation happens on top of that to produce outcomes that would have been, not possible otherwise. And while we can't change the physical infrastructure, public infrastructure in India, in a way, iSPIRT has committed itself for the last 10 years to try and build the world's best public digital infrastructure in India. And so that our entrepreneurs can leverage that as they go forward. Now, this is a major, major mindset shift. So we call this the athletic Gavaskar problem. Yeah, the game is changing. This is the old game. This is, you can call it the 5-day cricket. And this is now the 20-over cricket. The player that you need for this game is different. The player who's a good 5-day cricketer may not necessarily be a good 20-day cricketer. In fact, in cricket back in time, they had this project which was called colloquially the Athletic Gavaskar project. So the Athletic Gavaskar project was that even if they go to Kapil Dev and Gavaskar and say become athletic, they may not choose to become athletic because they're successful as they were. So they said if we need an athletic team for a 20-day overs game, then we must build it from scratch. And they started this process of building a new under-19 team under that program, which, as you know, went on to be very successful. I'm sure all of you know Virat Kohli went on to become the captain of that team. And now it's hard to imagine many cricketers who are not athletic in nature. So, and this is the story of almost everything. When hockey went from grass to AstroTurf, the nature of the hockey player changed. You still needed dribbling, but you also needed speed and stamina. And India actually fought AstroTurf for 15 years. Then our Indian players fought AstroTurf for 15 years. So we lost the game of hockey. Luckily, all that has changed and hockey is bouncing back. But this happened more recently, as you know, in wrestling. Wrestling, when it went from mud pit to the mat, the nature of the wrestler changed. A new wrestler was needed. Luckily, back, if you some of you are from the north, you know that the akhadas in Western UP and Haryana, which had a very strong self-image about wrestling. Their sense is they've been wrestling for millennia. They luckily embraced this idea and they changed. And India went for a little while from a hero to a zero, but then bounced back very quickly, and India continues to punch above its weight class. So this is a change that is now happening to Indian entrepreneurship. And this is a difficult change. It requires unlearning. This is what you will have to see play out if you are in a startup in your part of the world. If you are on the public infrastructure side, then this is a new role that you are playing, which is to provide high quality public infrastructure. If you are a regulator, this brings a new dynamic in place because this innovation architecture is different from the one that we had before. So I wanted to kind of lay the ground for this. And as you can see, I love to talk. So I'm now getting messages saying, hey, please finish. So I will finish here and hand it back to Kiran. Over to you, Kiran.
Kiran, you're on mute.
Thanks, Karthik. Sorry. So thanks. It was a really nice intro to not just iSPIRT, but also the history of how sporting is changing. So thank you so much for that. To bring, I think one of my biggest takeaways was really this whole architecture of public goods and private innovation. And while it's very fascinating to see that even in the case of India Stack, that this actually is an evolutionary process, happened over many years with many market participants kind of coming in. So clearly, I think even on health, we are at the starting point of this particular experience. Now, one of the things that I would like to, before I bring on Siddharth to basically talk a bit about it, let me give a quick short introduction. There's been a lot of talk and action on the health stack quite recently, and I'd like to also call out and thank many people who have actively been participated and been given feedback on the design. I think in the last 6 weeks, there's been significant response, specifically Shashank and Abhinav of Practo, Ajit of MFine, Gaurav of 1mg, Shamik of CareFit, Dr. Pramesh actually of the National Cancer Grid, Abhimanyu of Live Health, Ajit of Attune. So thank you all for taking the time, the effort to understand a lot more about what's been the national health stack and also give such positive feedback, which is also helping evolve the design. Now, iSPIRT, as Sharad explained, being a volunteer-led organization, and what personally for me has been fascinating is that they are very intellectual conversations, not driven by age. So we have volunteers of all age groups, and I'm happy to introduce our youngest one. I think Siddharth came in when I think he was 19 when he started as a volunteer with us. That's about 3 years ago. So Siddharth has been a very active contributor on what Sharad talked about as the DAPA framework, and many components, and specifically the personal health record component, which we will deep dive into today, is actually being built. A lot of learnings from DAPA that's being taken in. So Siddharth, if you can do a quick overview of the health stack and also with a focus on the personal health records, that'll be nice.
Awesome. Thanks a lot, Kiran. So the current, if you take a quick overview of the health system in India, it's completely broken, right? So we have one of the highest out-of-pocket expenses in the world, one of the worst doctor-to-patient ratios out there. And if you factor in quality, it becomes even worse. And what we're seeing is a fundamental shift where over the past 10 years, the disease burden has moved from infectious diseases to actually non-communicable diseases. And the treatment of non-communicable diseases is very different. So in the infectious disease world, you would have very transactional checks through diagnosis, medicine, eliminating the disease, and so on. But in the non-communicable disease paradigm, you actually need continuity of care. And the institutional structures for continuity, for post-care monitoring, for a range of these, be it diabetes, obesity, heart disease, and so on, is completely absent in the country today. And so therefore, the focus at iSPIRT over the past 4 to 5 years on the health side was how do we go about building a world-class health system for every Indian? And there are really 3 pillars that we focus on. The first is accessibility. The system must be accessible through various form factors to 1.3 billion Indians. The second element of it is continuity. So it must, through new technical standards and institutional architectures, and then various innovators building on top of it, both in the private and public sector, must drive continuity of care for these non-communicable diseases. And then the third is affordability. How do we do all of this at extremely low cost so that it can serve a broad spectrum of individuals across the country? And the way we see this happening is really using a 3-pronged approach. The first is improving efficiency across the entire care delivery system through strong digital infrastructure. And I will dive into what more commonly known as the plumbing layer of the health stack. Today, for example, if we wanted to know the total number of, let's say, neurosurgeons in the country, there is not a single registry that makes that available. Or even if you're a doctor, there aren't registries for a doctor to prove their identity in the digital world very easy. If you want to share your health record information, again, that's very broken. So we do need, much like what India Stack served as the set of building blocks, the digital infrastructure for financial inclusion, we need a very strong digital foundation for health in India. The second part of it essentially depends on realigning incentives across the entire care ecosystem. Today, everyone is optimizing for their own local optima, right? So providers essentially care about heads in a bed. The more heads in a bed, the more the revenue, the better the unit economics, right? Payers are essentially optimizing for withholding as much money from going to the providers as possible. And so no one's really batting for the patient in this ecosystem, batting for keeping them healthy. And if they fall sick, then batting to ensure that they get the right care treatment. And so how do we go about realigning the health incentives to drive India towards a wellness-oriented society? And for a lot of that to happen, we need to leverage the Ayushman Bharat program, which is the world's largest health insurance scheme. Essentially, it provides a 5 lakh cover to about 100 million households. And Kiran has been really driving the technology out there extremely well. And therefore, the digital plumbing that we envision that would make this happen is what we call the national health stack. The first layer, which is the plumbing layer, is essentially about streamlining the flows of health information, money, patients, and so on, and really building trust in the system. As part of the plumbing layer, there are 3 core building blocks. The first relates to electronic registries. So as I mentioned earlier, we have extremely poor master data across the nation. And so it's important that we build a trusted set of registries for medical professionals, so allopathic doctors, Ayush doctors, and so on. We build a trusted registry for all the facilities in the country, hospitals, small clinics, diagnostic labs, and others. The same for procedures and drugs as well. That allows for the first entry of trust to be established across the entire ecosystem. And for either of these entities, be it an individual or an organization, a way for them to prove their identity in the digital world that's being built on top. The second part of it relates to the flow of health information. So how does a patient, with consent, in an electronic manner, share their health information from a range of sources? This could be from a lab, from a hospital, medical images, and so on, linked with multiple IDs. How do they share that with, let's say, another doctor for a second opinion? So they can do that electronically instead of spending, say, 2 to 3 days traveling to the next doctor. And as a result, a lot of people often end up using quacks because those quacks are just accessible to them in a timely enough manner in those rural villages. And then the third part of the plumbing layer is essentially about claims. So as I mentioned, for us, it's very important that we transform India towards a wellness-driven society, right? Because insurance by itself, given the way it's proceeded in the West, is not going to solve all the problems. For that to happen, you need people to take regular checkups. Today, regular checkups are not covered in the system. OPD visits are not covered in the system, primarily due to the costs of claims processing. So it's anywhere in the order of 1,000 to 1,500 rupees and more in some cases. And as a result, all insurers only cover IPD visits. Because if I'm visiting a doctor to get a, say, full body check or a preventive health checkup, that doctor is going to charge me probably 200 rupees or 150 rupees and so on. But if the cost of processing that claim is 1,500 rupees, it's never going to work out. Much like what eKYC did, where it shifted the cost from earlier, a typical KYC being charged was about 1,000 to 1,500 because you had to hire a person, send them physically to collect documents and so on. And so the financial products that could be built on top were restricted given the margin difference. And eKYC dramatically lowered that, and as a result, allowed for new sachetized products to be created. We expect the same innovation to come on top because of the claims engine that's being built out. In today's session, I will do a deep dive on the PHR framework and how that would work. How would consent be captured? What are the flows of consent, flows of data? But I'll just give you guys a quick overview of the layers above. And then in the subsequent sessions, we'll do deep dives in each of them. The plumbing layer, like I said, builds trust. But the second part of this essentially addresses augmenting capacity within the current system, right? So like I mentioned, we have one of the worst doctor-to-patient ratios in the world. And therefore, it's important that we assist doctors in taking better decisions, assist the medical professionals in following the right protocols of care that's relevant in their environment. right? A lot of the, we do not have right localized protocols of care. And so we do expect an ecosystem of what we call diagnostic bots to come up, given that you have now unlocked access to health data, that they can then use and consume this health data to form predictions of various sorts, and those predictions inform a doctor's decision. And this is going to be possible because there's a fundamental shift happening in healthcare today where diagnosis is moving from symptom-based to biomarker-driven. And for all of us, we can see this play out in the current COVID crisis that's underway. You are unable to diagnose an individual if they have COVID purely on the back of symptoms like fever and cough and so on. Because in fact, 60 to 80% of people, depending on geography, are actually asymptomatic. And that's the reason why you do need biomarkers to diagnose that individual. In the case of COVID, those biomarkers are either in the form of RT-PCR tests or in the form of the antibody tests, IgG and IgM, and so on. Right? And we do expect a democratization of biomarkers to take place in the country. Today, you'd already experience a version of this. If you sign up for any body checkup, you'd often be thrown up a list of 50 tests, 100 tests, and so on. And the reason being, often the limiting factor in this is the reagents. And with a lot of the reagents now being produced and manufactured domestically, we are going to see a democratization of biomarkers at scale that no other country has seen before. What that allows, using consent, is that that biomarker information can now be shared, and bots can use this to inform the diagnosis of a doctor, thus augmenting their capacity. The second part of it is essentially laying in place the right protocols of care given the condition, given the environment, and ensuring that the patient or the individual goes on to follow that protocol. And then the third piece is matching the right individual with the right provider based on a range of variables. Today, individuals often, since the system is so primitive, what you'll often find is individuals from tier 3 towns will often end up in tertiary level hospitals, like say TMH in Bombay, although they should have gone to a primary care center. And that's primarily because they don't have information available at all about this. And much like systems that Uber, for example, which matches you with the right driver based on a whole bunch of variables, often competing, or Google, when it shows you an ad, is again optimizing based on a whole bunch of competing variables, or be it cost, but at the same time customer experience. There has been a lot of work that's happened in this space, especially in the domain of microeconomics, to how do you match the right individual with the right provider. And all of these technology building blocks will then be consumed by a new class of institutional entities that are created above it. They will take the form of preventive care fiduciaries. Essentially, these will be organizations that are batting to keep you healthy, right? They're economically incentivized on an outcome-based model to keep you healthy and manage your biomarkers extremely well. If, however, you do happen to fall sick, then you will have the right treatment care fiduciaries to take care of you with the right care protocols. Today, a lot of fraud happens where, let's say, you have knee pain, right? And the knee pain could actually be as a result of poor exercise. But providers will often suggest a total knee replacement because it's a commodity surgery. It's a quick way to earn a set of income and so on. So we do need a new set of institutions that treat patients the right manner. And all of this will happen only if we have a new class of insurers that come in, which is what we're calling as gamifier payers. And on our blog, we have published a detailed paper on this. Saurabh from iSPIRT has worked on it, and I'd suggest you guys give it a read. And on top of this is where you'll have a range of apps, both on the consumer side, both private sector apps, public sector apps, as well as different middleware players, which is your health information systems and your lab information systems that build on top of this infrastructure, consume it, and really serve the needs of the folks on the front lines. So I'll dive straight into the PHR section. But just to set a bit of context on...
I want you to go back to the previous slide, just 1 second. See, I think we want to emphasize a lot of discussion around this is around teleconsultation right now, because that is beginning to go mainstream, largely because of COVID. The government has formulated new guidelines. So therefore, what was kind of semi-legal now is fully legal. And our expectation is that teleconsultation will become big over the years. You, at a first glance, you may think that it doesn't belong in this, but it does. It is in the layer that said you can move your arrow. It is in the layer, in the top 2 layers of the private innovation. So Arogya Setu, for example, would be a public sector consumer app, but there would be, of course, many private apps that would happen. So although in this version of the slide, you don't see Arogya Setu, it is there. You don't see all the telemedicine players. They're all there in the second layer that you see from the top. So I just wanted to mention that, given many of you are coming from that perspective.
Cool, thanks Sharad. So just for context, before we dive into the specifics of the flow of health data, PHR is essentially a component of the larger data empowerment and protection architecture, or DAPA as it's more commonly known. And this has been underway at iSPIRT as well over the past 4 years. And the reason is, if you look at the trends that are taking place, right? Indians are going digital. In the health space, for example, a lot of your information is already generated in electronic formats, like your diagnostic test results or your images. The same in finance as well, is what you're seeing play out with financial transactions becoming digital. A lot of this is possible because connectivity is now permeating, thanks to 4G and others, to the rural hinterlands. And with the new platforms that are coming in, the likes of India Stack and the Health Stack, it actually makes this infrastructure available and consumable as time goes by. And therefore, it's very critical that as Indians become data rich, they are actually empowered with control over their health information, right? So in the old paradigm, data was essentially used to sell things to the user. And for a lot of us, that's been our lived experience so far, where it's used to sell you things through the form of ads and other stuff. And we've seen how broken that has turned out to be. And therefore, in India, we do want to build out a system where people are put in the center of their data flows and therefore empowered to use their data to access better financial services, health services, and so on. Given that data is a fairly abstract term, I'd like to, like all of us, to first align on a standardized vocabulary. And the way we categorize data is essentially into 6 types. On one end of the spectrum, you have what we call non-shareable or secret information. This is the biometrics you submitted to Aadhaar or the PIN and password that you used in any application. And this is something that never gets shared outside that environment. And on the other end of the spectrum, you have what's classified as public data or open data. So these are high-level statistics. For example, let's say the COVID count in a particular region or economic activity in particular districts and so on. Within this, you have a set of information that's linked with the user's identity, which is personal data, generated data, and derived. And then you have information that's de-linked from a person's identity, which is the anonymous data set. For the information that's linked with a person's identity, it's critical that sharing of that happens with users' consent. And if you look at it, personal data is nothing but your name, date of birth, gender, basic demographic information. Generated data is any data trail that gets created as a result of any transaction with the platform. So let's say you swipe your card at a POS terminus, the debit in your, the debit that shows up in your transaction statement as a result of that is a class of user-generated data. Or you use Google Maps and the lat-long stream that got generated from that activity is also user-generated data. Or even, let's say, the diagnostic report that got generated at the end of a lab test. Now, whenever you apply a set of algorithms to this raw data is when it gets classified as derived data. So imagine your CIBIL score. Your CIBIL score is nothing but a set of underwriting models applied on top of your financial transactions, the credits and debits in your bank account statement, right? Or let's say a doctor's decision after looking at your raw data would get classified as derived data. And anonymous data sets are critical because for India to build out an ecosystem of strong machine learning models, it's important that the startups in the country get access to these anonymized data sets. And today, it's only possible for an MNC to do that when they partner with large providers, and that's what we see world over. And so there is infrastructure being built out to sachetize this so that a startup can access anonymized medical records, anonymized loan information, and really build competitive models that are relevant to the diverse demographics of India. Otherwise, a lot of the decisions end up being on the back of Western scorecards and Western models. Within this, I'm now going to walk you guys through sharing of personal and user-generated health information with their consent. And so way back in time, the Ministry of IT, this was about 2016, the Ministry of IT published a national standard for electronic consent because it's important that we codify consent. There are various aspects to consent. What data you want to share, with whom, for what time period, for what purpose, and so with what frequency, and so on. And therefore, in 2016, MIT published this as a national standard. And it's based on a set of principles known as organs. So O in organs it's an open standard. This is what got adopted in the financial sector by the 4 financial sector regulators, RBI, SEBI, PFRDA, and IRDA at the FSDC level. And the same standard is now being adopted for health data as well. The second part of it, R, is it's revocable. So I could give consent to share my health records every week for the next 4 weeks with a doctor who's monitoring my care, but go back and revoke it at a later date. G is the consent is very granular. So rather than sharing the entire longitudinal health records of mine every time with every doctor, with every provider, with every health app, I can actually consent to share only parts of it depending on the purpose and use case. So it could only be sharing, say, the output of a particular parameter in a diagnostic report rather than all my diagnostic reports and medical images put together. A in organs is it's auditable. So structured audit logs are generated every time consent is created, data is shared, and so on. N is notice. So just like when money leaves your bank account, you get notified through SMS and email. In the new paradigm, when data is shared about you, you get notified as well. And S is it's secure. So the entire data flow is end-to-end encrypted. And one can layer additional levels of authorization on top of this consent artifact. So for example, in the context of healthcare, one could delegate consent to other, let's say, a spouse. So in the case of a particular medical condition, the spouse can authorize sharing of those health records. Or one may allow for doctors in the case of, let's say you are unconscious and admitted to an emergency room, then the doctor that's part of the doctor registry could electronically access your health records and an audit trail attached to that would exist as well for accountability. And the same set of organs principles are essentially what have been encapsulated in the Shri Krishna Data Protection Bill, which is the Uber level law that empowers users with control over their data. They make unconsented flows of data illegal. And they also establish a right to data portability. through consent managers. So a user has a right to port their data from one service provider to any other service provider in a machine-readable, structured manner through a new class of institution that are called consent managers. So the first example of a consent manager is essentially the account aggregator that's regulated by RBI. The AA, one way to look at it is in the old paradigm. Let's take an example from UPI, right? So in the old paradigm, you wanted to make a payment transaction, right? So you would go to the custodian of your money, which was your bank. You log in through net banking and issue an instruction saying debit my account and credit the end destination. Now that was a hugely painful experience because banks are not going to create diverse front ends for a range of use cases in India, whether it be an individual that wants an assisted flow, whether that be a small kirana shop, other MSMEs, and so on. But there are legitimate reasons for money to remain within the bank account, within the regulated entity, reasons of consumer protection, reasons of monetary policy and transmission, and so on. And therefore, in the case of UPI, we essentially unbundled only the permission out from the bank account and placed it into third-party innovators, which are what PhonePe, Google Pay, WhatsApp Pay, Bheem, and others do today. So these apps are nothing but permission collectors, right? So you register with them, you link your bank account, and all they do is they collect your permission on your behalf. So let's say you link your bank account, you got a UPI ID, let's say that was Siddharth at the rate of Bheem, and then you go to a merchant the next day, and the merchant asks you, okay, in order to pay for these set of goods that you want, please give me your UPI ID. So I hand him over Siddharth at the rate of Bheem, he inputs that, and in real time, the merchant sends me a collect request, a UPI collect request. And then I look at that collect request, I say, okay, this is the merchant, this is how much he's asking for. I input my PIN and authorize that transaction. And so at that point of time, a digitally signed version of my permission is captured and shared with the custodian bank, who then debits my account and credits the end destination. And given the success of UPI, we essentially said, hey, why couldn't this be generalized and applied to data? So why can't data remain with its custodians, right, in a federated manner? But why couldn't I go to a third party that manages just my consent? Because in the data paradigm, your permission is nothing but your consent, right? Link wherever my data resides. And then on a transactional basis, let's say I was going to a lender who wanted access to my financial records. Then for that transaction, I consent to sharing that financial information from the custodians with the lender in an end-to-end encrypted manner. And that's exactly what the consent managers facilitate, right? So on the left-hand side, you have your custodians of information, or more commonly known as financial information providers. This could be a bank, a mutual fund depository, and insurance repository. So the account aggregator policy covers a whole spectrum of financial information. And these essentially expose a set of standardized APIs to the financial consent manager. And these standards have been already implemented by some of the largest banks in the country. So HDFC, Axis, ICICI, SBI, and so on, within a closed user group. The user can register with any account aggregator of their choice. And there have been about 8 that have got an in-principle approval, 3 with an operational license, and link their bank accounts and other information and get an AA ID, say Siddharth at the rate of AA1. And I can now go to a lender who says, hey, in order for this loan application, give me your AA ID. So I give him Siddharth at the rate of AA1. Of course, this can be discovered through deep linking. You could have SDK flows and so on. I'm not getting into the nitty-gritties of the UX at this point in time. But a very primitive version of it would be I give him Siddharth at AA1, and then in real time, he sends me a consent request. I look at it, it's structured to me in an informed manner. Different AAs can build different front ends depending on if they're serving individual consumers, if they're serving MSMEs for sharing of GST data, if they're serving enterprises and so on. And once I approve that consent and authorize it, at that point in time, a digitally signed consent artifact, which is what I just showed you earlier, gets generated by the AA, who then sends it to each of the FIPs, who then return back data in an end-to-end encrypted manner in near real time. And then, of course, I can authorize a recurring consent, say the lender wants to monitor my cash flows. I could authorize that, and other use cases like wealth management and robo-advisory and so on. And so if we look at it, the health sector, in fact, is even worse than the banking sector today, right? So in some ways resembles banking in the 80s, where it was branch banking, right? And each branch had its own information stored on its own information system. In fact, in the central office didn't have a view of the finances across its own branches, let alone transactions happening between different banks, right? And so the health sector, from the point of view of information, is on similar lines, right? And the patient goes to multiple providers. It could be a lab, it could be a clinic, it could be a hospital. And at each of these providers, a range of data gets generated against that user's identity, right? And some of it today is generated electronically, although in different formats. A lot of it isn't, say a prescription, for example. And so this will be a long-term journey where one starts with establishing access to data that's already generated electronically. And over a period of time, as more and more information becomes electronic, like prescription, then that gets shareable as well. And today the patient is essentially using a physical folder, trying to move this information around. And that blocks them from accessing second opinions and various other modes of care in the health system today. And so we've essentially, the first step was designing a way for that user to discover all of their health information. And so we've defined a standardized discovery protocol. So let's say the user went to a lab and used their PMJ ID because they were covered as part of Ayushman Bharat. And then subsequently they went to a clinic, and the clinic at that point in time just asked the user for their mobile number and demographic details. And then they went somewhere else and used their Aadhaar. So the patient information is out there linked against multiple IDs. And so we've essentially defined a discovery protocol through which a patient could register with a health locker of their choice, and there will be multiple, and actually go ahead and discover all of this health information, because each of these IDs that I've outlined here are digitally verifiable, right? And then aggregate all of their records in one place. So there is no use of a unique identifier at all, but in a federated manner, through user consent, you're actually able to aggregate all of this health information and create a longitudinal view of your health records. At that point in time, the question arises of storage. So where does this health information reside? And our belief is that this too should happen in a federated manner. And so there'll be two possibilities that take place. One is the providers will partner with an ecosystem of repository providers. This could be the already existing, let's say if it's a lab, then it's already existing lab information system or an already existing health information system that offers this as an adapter. And therefore, it's critical that this ecosystem of repository providers, or what we call API bridges, comply with the set of standardized APIs for receiving consent and sharing that health data, and also facilitating the discovery and linking I spoke about earlier. And we've also defined these standardized APIs, and I'll in a subsequent slide, share the link with you as well. And therefore, a user can now go to a health locker, and based on the discovery protocol, since these repository providers are complying with the standardized APIs and they'll be certified against that, aggregate all of their health information. And so the health locker just stores pointers to their health record, but never the actual health record itself. But some patients may happen to have data that they have kept physically that they may want to scan and upload. And for that purpose, they may upload that to their health locker or store duplicates of that information with their health locker. So that is completely patient driven. And in light of that, the next step is I have now linked my health information. It is accessible, it is discoverable, but I now want to share it with a treating doctor, right? So let's say I've got an opinion from one doctor and I want to visit another doctor to get a second opinion. And I want to do this digitally because I cannot physically travel. And for a lot of Indians, even a day worth of travel means they're not going to get that daily wage, and a whole bunch of problems ensues from there. So if I want to share that digitally with my treating doctor, that has to happen with consent. And so the same Ministry of IT electronic consent artifact that I showed you earlier has been implemented in this framework as well. And we didn't want, there were two architectures available, right? One is consent gets collected on either end of the spectrum, either on the treating doctor's end, right? So let's say the treating doctor is using some telehealth app and consent gets collected on that app, right? And they act as a consent collector. And the problem with that is they'll never go on to create informed consent experiences. There will be a diverse range of apps that want access to a user's health data. So they'll never focus on creating the informed consent experiences that meet the guidelines laid out in the draft data protection bill. And the other alternate was the health locker collects it, or the custodian, right? And as I outlined the problems earlier with the custodian collecting consent or the custodian collecting permission in the data paradigm, we essentially unbundled the management of consent from both ends of the spectrum and have placed it within the construct of a consent manager or a health data consent manager. Again, you will have an ecosystem of health data consent managers. Some will focus on self-service, some will focus on assisted, some will focus on India 1, India 2. They'll offer a range of developer experiences and so on. But a patient can go to any one of them, given the interoperability in the system, and discover and link all their health records with what are called health information providers, right? And then subsequently share that health information with any health information user. So this could be the doctor for a second opinion. It could be as part of a claims process. Today, one of the biggest issues in the system is actually timely processing of claims, right? And since none of it is electronic, in some cases it's done in 45 days, in some cases it's done in 1 year, in some cases claims processing and final money settlement takes even a year and a half, right? And as a result, providers don't participate in any of these programs. And that delay causes enormous strain on the cash flows. And as a result, providers are incentivized to facilitate sharing of electronic health data as part of that claims process, which will be a bunch of records generated through that, of that patient, through that care context, that can now be shared with the TPA/insurer with the patient's consent. And as a result, the claim can be now almost adjudicated in near real time for maybe 98, 99% of them, right? Or I could also consent to share my health data for a monitoring purpose, for tracking and sharing a time series view of my exercise records reflected through steps and other information that comes out of accelerometer and gyrometer sensors. So there's a whole ecosystem of health information users that will come up now that users have been empowered with control over their health data. And all of this is happening, this entire flow is happening without getting stuck in the entire standardization debate that happens world over. So our belief is technology moves so fast that you actually don't need to agree on a single standard from a health data perspective across the country to get up and running, right? So therefore, in phase one, we do expect providers to attach embedded schemas right? So each provider may have their own schema. If they run on common software systems, then many providers will follow a common schema of that software system. And that can be shared along with the health records, so that when the health information user receives that information, the algorithms can actually interpret it on the back of that embedded schema, and then combine it into a single view and feed it into whatever is the downstream health information system, and so on. We do expect as well, and there is a parallel track that's underway on to make this easier, coming up with a data dictionary or a vocabulary in a voluntary manner that different software providers can adhere to. And so a standardized vocabulary or a data dictionary for diagnostic test information is currently underway, right? So therefore the consumption becomes a lot easier. You don't have to do a lot of ETL. And that's just one way to make adoption a lot quicker and consumption a lot quicker as well. And all of this is possible with very minimal change to the existing health systems out there. And so to summarize before, I'll show you guys a demo that brings this to life, is essentially the three core parts of the personal health record framework are: one, it's completely federated, right? So the data is stored in a decentralized manner by the custodian, and the custodian partners with an ecosystem of tech companies that provide adapters to this network in a standardized API. The second piece of it is it's privacy protecting, and in fact even enhances the privacy of a user through the use of consent managers. And then the third is with minimal change to existing health data schemas, one can actually get this up and running. And this is already up and running in a pilot mode with the National Cancer Grid. And I'll run you guys through a very quick demo. It's extremely primitive, so we didn't put in a lot of focus on the UI UX of it, because that's what you guys will innovate on, and really wanted to show what the underlying flows are. So I'll just switch over and run you guys through a quick walkthrough of that. Okay. Yeah. So the first step that I'm going to show you is a patient registering with a consent manager. So through a simple mobile number OTP flow, they're able to self-register. At that point in time, they then need to create an account with that consent manager. So in this case, it is being hosted by the National Cancer Grid, which is a network of 100+ oncology hospitals across the country. Speed it up a bit. So this is essentially Hina Patel's consent manager ID, right? Much like your UPI ID, that you can then give to a health information user for them to send back a consent request. The next step, now that the patient has registered with the consent manager and created their ID, is actually linking their health record information, right? So this patient went to Max Healthcare and wants to link the information or the care contexts that were generated through that interaction. So at this point in time, the verified mobile number of the patient is being sent through the standardized APIs to Max Healthcare, who will then return back a list of masked care contacts. And This discoverability is extensible. So if there are other IDs available, like say a PMJ ID that's digitally authenticatable and the health data has been linked to that, then that too can be passed. Or additional metadata. Sometimes health records are linked to the same mobile number, but the demographic information is different because people share mobile numbers, in which case then you have to pass the mobile number plus the verified demographic details to fetch it. And so these are a list of linked care contexts that show back up of Hina Patel, and she chooses which one of these she then wants to link with her consent manager. When she links, that does not imply that the health data is moved from Max Healthcare to her consent manager. All it implies is a long-term session has been created between the two, so that subsequently when she wants to share it, she does not have to authenticate with each of the providers all over again. In order to establish this linkage, Max Healthcare needs to verify Hina Patel, and so they send an OTP to her mobile number, which she just inputted. Again, the UI and UX of this has really been just to show the underlying flows, and you can innovate a lot on discoverability, making this more and more automated, easier to understand, and so on. The next step is Hina Patel now visits a doctor, right? And the doctor wants access to her health record information that was linked. So the doctor raises a new consent request. Again, this can be embedded, integrated as part of the existing health information system out there as well. And the information being requested for can be pre-selected, but we've kind of called all of it out here to show you guys how it works. So the patient ID, which is their consent manager, is what the doctor has inputted as a health information user. It describes the purpose of why they want access to this health data, the period with which they want access of this health data, as well as what types of health data do they want, diagnostic reports and medication history, other observations from other previous doctors, and so on. Again, it's basically configurable depending on the purpose. So you don't need to access all health data at every point in time. And you can also have an expiry date attached to that consent, and then the consent gets requested for. So at this point in time, this health information user raises a consent to Hina Patel's consent manager, which is NCG. And so in real time, Hina Patel in her consent manager app now receives the consent request. So she sees Dr. Lakshmi is requesting for this data. It outlines the terms of that consent, for what purpose, when will the consent expire. She may also edit the type of information that she may want to share. And then she goes on to grant consent, which happens to the input of her consent pin. So now that she's granted consent, the consent artifact is now generated by this application and then sent to the health information providers that Hina Patel linked, who will now return back data directly to the health information user. So the data does not even flow through the consent manager. It goes directly from the HIP to the HIU. So we are back on the screen of this doctor, and the doctor has now received this health records in near real time, and she can view this and come up with the relevant decisions. So this is a quick overview of the PHR system in action. And I'll just double click.
Yeah, just sorry to interrupt, Sid. I just wanted to, the whole PHR design has been in the works for quite a bit. And what you saw here was actually made possible because about a year or a year and a half ago, the National Cancer Grid decided that for their cancer patients, it would be very important to have a full longitudinal record as well as just history, because they told us that many cancer patients do visit multiple hospitals across the network, and they wanted the portability of data. I'd like to just acknowledge that the ThoughtWorks team, who has been working with the National Cancer Grid, has done all of the initial development and the UI and the flow that you see, which at least brings the idea to life. So go ahead, Sid.
Yeah, thanks, Kiran. And this is essentially a double-click version of what you just saw play out. So for the techies on the call, this will explain the inner workings of the system. So on the left-hand side, you have the health information providers. And like I mentioned, there's huge fragmentation on this part of the ecosystem, right? Much like the branch banking was of the 80s. What I mean by that is even the largest hospital chains in India run their own custom software or health information management system, right? A majority of the labs also have custom software implementations, but we are seeing a bit of organization in the sector. And there are a bunch of lab information systems out there that have actually captured the market, the organized market of labs fairly well, at least 30% of it. And therefore, it makes it easy for these 30% of labs through with a simple feature update to become part of the network. And then, of course, you have various small clinics and small hospitals that are part of different aggregator softwares out there. And so the question was, how do we make it very easy for them to become part of this network? And this is through an ecosystem of API bridges. You can imagine them as a set of incentivized technology partners that go out there and rig up the last mile connection, right? So much like you have an internet gateway and then you have a set of last mile ISPs that go in different regions and rig up internet connectivity, we do expect a similar class of entities to come up out here, right? And a few of them have already started building in that direction. Essentially, what the API bridge does is on the southbound end complies with the standardized APIs that have been outlined. But on the northbound end, they are free to innovate. So there has been no standardization of the APIs on the northbound end because you can offer various experiences. Some API bridges will go down the path of, say, I'll offer a stripe.com like experience with one line of code and any LIS and HIS can come on board, right? Or some API bridges will go down a services model saying we will connect you guys in a custom manner and bring you on board. Some will say we only have a cloud solution. Some may say we also specialize in on-prem deployments. So we will have an ecosystem of API bridges coming in that facilitate connectivity to the network. And these are all certified entities, right? On the right-hand side, you have the health information users. So let's say a teleconsult app, for example, that now wants to request consent and receive the data to show it to the doctor that's part of the teleconsult platform. They too will use an API bridge. Again, the API bridge on the southbound end complies with the standardized APIs, the standardized HIU APIs, and on the northbound end is free to innovate to make it very easy to integrate between different HIUs. And given the interoperability in this ecosystem, it doesn't matter if an HIU has chosen API bridge 3, it can continue to receive requests from any HIP in the system, no matter which API bridge it is partnered with. So this dramatically expands the addressable market out there. The users are essentially interacting with the consent managers, right? Which was that app that I showed you earlier to approve consent. And the routing and discoverability, the discoverability of the endpoints, the routing of the consent requests get facilitated through a gateway. However, the final data flow, which is what you see in red out here, happens directly from the health information provider to the HIU. It doesn't go via the gateway, it doesn't go via the consent manager. It goes directly to the HIU. This is possible primarily due to the advances in connectivity that have taken place over the past few years. If you want more details of this, the detailed specs have been out for a while on GitHub. So you can actually click on this link and we'll circulate the deck after this. And you'll get all the API endpoints that are available. So let's say if you're a HIU interested in consuming health data, and what are those APIs? If you are an API bridge that's enabling this activity, you can just open it up and go through it. These are Swagger YAML files, and if you just go through it, you'll get all details of the APIs. And there's already an open source implementation that's been up and running on this link that you can take a look at and plug into and build upon. So if you are interested in participating in the pilot that's taking place, the open source pilot, either as a health information provider, so hospital, lab, or any other such entity, or if you're an API bridge on either end, enabling providers to become digital or enabling entities to consume digital health data as an API bridge, or if you're an HIU, or even if you're interested in being a consent manager, please feel free to drop us an email at community@iSPIRT.in. The docs are public, the API docs are public, the code base is public. So I'd strongly suggest you guys go through that. And then if you have any questions, feel free to reach out. So that's about it. We've essentially covered a quick overview of iSPIRT, the national health stack, double-clicked on the PHR component of the national health stack today. And I'd strongly urge you guys, especially for the techies on the call, to go through those standards, offer feedback. There is a parallel track even on the dictionary, data dictionary that's taking place. So if you want to contribute in any way, please feel free to reach out. Next Saturday, we will do a session on the doctor registry piece. So the question is, how can a doctor in an easy, secure manner digitally verify themselves on any platform? And that will happen through what we call electronic know your doctor, or eKYD, right? And so any doctor in India will be able to be a part of the doctor registry, get verified, and share that KYD information with any platform in the digital ecosystem. So we'll run you through those APIs and those workflows next Saturday. And so feel free to register on the link that I outlined.
Yeah, can I?
That's about it from my end. Over to you, Sharath. Thank you.
So the reason we've circulated a Q&A link for on Google Forms is that we said, if you go back 2 slides, we actually want you to go back to this, the GitHub repository, go through the technical documents, post your technical questions in that place. So now if you come back to that last slide, Sid, when we start the next Saturday discussion, we want to start by answering your technical questions on PHR. And so if you want to reach us, please put those technical questions on the Google form. For some reason, if you don't have that address and you can't access that form, send them on community@iSPIRT.in. You know, in the subject line, please say PHR technical questions, so that we can separate them out and address them in the next open house. We're going to use several next Saturdays to talk to you about various pieces of the health stack. So we'll do this next Saturday. We have claims engine to do. We have many other pieces to cover, but we'll cover them one at a time as we have done.
There are several questions that have actually come in today. So would you and Sid be able to take a few of them now?
Yeah, we have 15-20 minutes. We can do that.
Yeah, thanks so much. So I think there's one I'm just going to scan through because there are quite a few, and I think largely the nature of today's conversation is supposed to be mostly for the tech guys. But one question was, is the health stack just for allopathic kind of treatments, or is it for any form of medicine?
Can we go to the stack slide here?
Yeah.
So while Sid brings up that stack slide, the health stack slide, the lowest layer of that, which is the pipe, this is the plumbing layer that you see, applies to everything. In the Ayush doctor cases, we are pushing the system to also start building their own protocols that are available to Ayush doctors. If they do that, then they can leverage the protocol server infrastructure that will be available. But what the plumbing layer would do is essentially manage the flow of patients' health and information, and claims within the system. And that would be available both on the allopathic side as well as on the Ayush side.
Sure. So I think the other query was, of course, a longitudinal health record is definitely very valuable from, say, a non-communicable disease and history perspective for sure. But given that COVID is right now on us, and India is still very large on the epidemic diseases side, one of the queries was, does the stack actually help in these kind of scenarios? So either of you can take that.
Yeah, so I'll just go back to 1 second. Categories of data slide out here. So if you take a look at it, what we walked through today was really sharing of the personal health record information. But when you look at it in the current COVID crisis, and I'm assuming the person is interested in access to epidemiological data, right, which is COVID counts in a region for public health purposes, deciding what parts get opened up and so on, that actually fits into the public data set or open data piece of the stack. There's already a national open data policy that has been put out. And what we do expect is the API bridges that I spoke about earlier that are facilitating the flow of personal data will go on to later even offer APIs for programmatic access to open data, right? So today, say the COVID count is done in a very manual process, integrity is not maintained because it's uploaded on some portal and so on. So just like you have automated compliance reporting and automated sharing of certain statistics that are published, right? In the server world, those are uptime stats published on a dashboard. We do expect the API bridges to play that role going forward.
Okay, so you're saying that, for example, the government would have or public or usable data, like say number of dengue cases in a certain region would become available because of that approach or infrastructure.
Yeah, so what's very critical is when you look at it from an open data point of view, it's important that firstly, a minimal set of data be specified. The second part is the structure be specified as well, right? So what is the structure in which you want that data to be shared? That structure can be enforced by the API bridges, but if that's not specified, it becomes very difficult for providers to comply. They're like, what data do I have to share? What purpose? From what DB do I have to fetch it, right? So minimalism of the data, ensuring it's spec'd out early on, and it essentially relates to statistical information. We shouldn't, many a times we mix up between personal data, non-personal data, and open data, right? Personal data is any information linked with the individual's identity, which requires consent. If I delink that information from the user's identity, it falls into a bucket of non-personal data, right, or anonymized information. And only a part of that bucket, which is high-level statistics and can be openly shared and is non-IP violating, then gets classified as open data.
Sure. Thank you, sir. There are a couple of other questions, and Sharad, it'd be good if you can take this one. Regarding, there are standards including Fire 4, HL7, and also there was a slide on schema and how we see, given that health data in India is going to be mostly in non-standard formats, how is the health stack viewing this non-standard data and the direction or towards standardization on certain things?
Yeah, Sid can also add to this. So there are two fundamental principles that are work for PHR. One is that PHR favors, as Sid pointed out, a federated data architecture rather than a centralized data architecture. And I'm happy to say that there is broad consensus that has emerged around this, even in the health space, including with many of the government agencies. The second big innovation in PHR is that it doesn't require a schema-based approach, and in fact allows for embedded schema approaches to come in, which means that if you have data where you can embed the schema in the data itself, then it becomes shareable. So it heavily promotes this embedded schema approach, sometimes called the universal data language approach. But it does hope that over time, broad schemas will emerge. And I will request, this is exactly what we are doing in the financial industry side. But maybe this is the place where, Sid, you can explain how what are proprietary schemas gradually at the discretion of the owner of that schema begin to become more like de facto standards. Do you want to spend just a few minutes describing that scenario, and because we are hoping that that would happen in the health space as well?
Surely, Sharad. So, in fact, given the rollout of the account aggregator in the finance sector, and the policy covers over 20 types of financial information, ranging from your bank account statement to your NPS balance to even equity shares, we ran into a similar problem. For something as simple as a bank account statement, there were multiple formats out there in the market. Each bank, each cooperative bank and others had their own version of it. And you'd often have a class of players that were still able to take in these multiple versions and combine it and offer a single version to the bank, right? But that really limited scale of this ecosystem because consumption of this data, integrity of it became a huge problem. And so in the account aggregator space, they became consensus on a common vocabulary with which, say, a bank account statement could be described. So if you go to api.rebit.org.in and you click on FI types, financial information types, you'll actually see a list of schemas, that common financial data vocabulary that have been arrived at. Again, those are not mandated on the players, but what we're seeing is it makes it very easy. Let's say a bank wants to participate as a provider of data. The first question is, what data do I have to provide? And if you have a ready-made vocabulary out there, they are able to look up that vocabulary and say, okay, these are the 10 parameters I need to provide in this structure, please go ahead. If they don't have that vocabulary, then they're looking all over the place. And that's what happens in the health sector today. So if you see the diagnostic labs, right, especially the smaller clinics, you see a similar trend. So the smaller clinics look up to the larger clinics and derive their schema, right? Then the larger clinics are changing their schema as time goes by, and the smaller clinics don't. And so you have this huge fragmentation out there. Also, international standards like LOINC don't have a direct one-to-one mapping to the Indian care context. On the ground, the vocabulary used for the way to describe, say, a blood glucose test is varied, right? And therefore, it's important that, much like finance, and there is a track underway already on this, we come to create a common vocabulary for describing a diagnostic test. So any vendor, software vendor, small or big, can look up that vocabulary and consume it. But like I said, it's not a blocker for go live. It only helps in consumption as time goes by.
Okay. So what I understand is that this is a evolving problem at this point, and we have a view, iSPIRT has a view on how this should probably kind of play out, but it will definitely require, seems like it will require a lot of inputs and collaboration from the various implementers kind of as it goes along. Now, Sharad, another question that's come up here is that, this DEPA architecture is putting the patient at the center, and there is this consent artifact, and we learned that the consent artifact can be very granular. Even the demonstration showed that there's a lot of choices that can be made on what is being consented. So some of the questions are, is the whole consent, can patients really understand this level of consenting, and how do you see that kind of evolve? And is, for all the different kinds of cases that may be probably required in healthcare, does the consent artifact, is the consent artifact ready? Is the design really support everything that we would want?
Yeah. So I think the consent artifact is ready, but the point about how do we make it extremely usable for India 2 and India 3 patients, India 2 and India 3 citizens, is a very good one. And this is where most of the private innovation will come. Now, having said that, we are reasonably confident that this will happen, because we have about 238 people on the bridge, and I would say almost all of them use a version of this with UPI. That all that PhonePe and Google Pay are doing in this architecture is they are consent collectors, nothing else. They're only in the consent flow. They're not in the money flow. So when you make a payment from PhonePe, money does not flow through PhonePe. Money flows through the sponsor bank that PhonePe uses. It doesn't flow through PhonePe or Google Pay for that matter. So their role is that they have to make this easy to use for the individuals, and that is the place for private innovation. And in fact, the people who do the best job of it over time will be the ones that will be successful. If you remember the very early days of UPI, between what the UI used to look in August of 2016 and what it looked, let's say, in January of 2017, in those few months itself, there was a radical change that took place once the private players came in and started. Pure play private players came in and started innovating on that. So we expect the same to happen here. But this is a very good question. Ultimately, this has to be simple enough to be usable by India 2 and India 3 citizens. That is our goal as well. We think private innovation will help us get there.
Sure, I think, and Sid or Sharad, you can take this. A couple of participants have asked, do you guys see a role for blockchain in the health stack?
So both of us can answer that. First, I'll make 2 points. The first point is all of health stack and India stack allows for implementation architectures to be implemented based on whatever is the contemporary technology of that time. So it is our expectation that these are 20-year, 30-year kind of architectures, and the underlying implementation technologies will change. Now, we are very, very sure that at some point in time, blockchain will come as the implementation technology, for example, for the registries, for parts of the claim engine, all that will happen. We don't, however, expect that to happen in the next 2-3 years. So I'll give you an example. Why is that? Because take UPI transactions. Every UPI transaction, let's say I send some money, 10 rupees to Kiran, and Kiran has a dispute. He says, I got only 5 rupees. Then what will we do? We'll go back and look at the digitally signed UPI transaction to sort out, adjudicate this dispute. And that transaction is signed by NPCI today. Now, tomorrow in the blockchain world, that would be signed by a group of people. It would be a consensus kind of a protocol that would be used for signing. That signature today is the cost of that signature is way too expensive to be used for 1 billion UPI transactions a month, which are growing very rapidly. So those costs have to fall in our minds by 10 to the power 4. And as you know, technology evolves very quickly. We think getting a cost down to by 10 to the power 4, 1/10,000 is probably only a 4-year, 5-year, 6-year problem. So eventually it will come to a cost structure that will be suitable for India. Right now, we don't think it is for these high volume transactions that we are looking at here in India. But if somebody has a solution for this, it is absolutely possible even today. It is implementation architecture agnostic. Sid, would you like to add anything to that?
Yeah, I mean, the only thing I'll add in addition to that is a lot of the principles from the blockchain world are very similar and have been applied in this context as well. So the decentralized nature of data storage, right? In our case, data continues to remain at the edges, either with the provider, it could be even stored locally within the consumer's device, and so on. The use of various cryptographic primitives like digital signatures and hashes are a key part of establishing trust programmatically in this architecture. So a lot of the principles that are behind some of the infra that's being built out in the blockchain world have also been applied out here as well. But like Sharad said, the current consensus protocols aren't ready for some of the country scale applications at this point in time. But if anyone out there is has ideas around this, really happy to dive deeper and discuss.
Sid, on the flow that of PHR that you defined, there was one query specifically to the discovery of records with healthcare providers and the consent on that. So one of the questions is, if I forget, so one of the query was that if I forget any ID that I have with the healthcare provider, will I still be able to find it and link it? Is there any thought process on that?
Absolutely. That's been a key part of the design. And in fact, we've published it in great detail of how the discovery would happen. So let's say a patient lands up at a provider, could have forgotten their consent manager ID, or they land up at a consent manager and they've forgotten their provider IDs, right? And so there are lookup mechanisms that have made a part of the architecture so that you can have some form of authenticated search and discovery, and then you recover that ID and the patient proceeds with linkage. What we also expect over a period of time is currently for historic data, it is linked against a disparate set of IDs, right? But as time goes by, people will actually use their consent manager ID. Let's say Siddharth at the rate of CM1 the next time they go to a lab, right? And so when I go to the lab, I give them Siddharth at the rate of CM1 instead of my mobile number and demographics. And then they will, when the lab tests are ready, push it against that ID, much like your email address, right? So you start off with multiple, and you may go on to keep multiple email IDs as well, to keep your professional life separate, your private life separate, and personal life separate, and so on. And the same applies in this case as well. So while people will end up using common IDs, and their CM ID would become a common ID, so it makes discoverability and lookup a lot easier for folks that want to maintain independent IDs, independent CMs. That is also possible. And these are all innovations that can be built on top by the private sector. So assisted lookup services at a provider and so on that make this happen.
So just to build on this, I would encourage people to really spend some time understanding our kernel level discovery protocol that underpins the health ID and therefore the CM ID. And we were trying to reconcile two competing things. On one side, we wanted every Indian to have a longitudinal health record, even though the health information is actually dispersed in various federated places, right? We talked about a federated kind of a data architecture. At the same time, we wanted people to be able to keep a logical separation, keep their sexual history, keep their reproductive health history, keep their mental health history, their general health history separate as separate health IDs, which they may not ever want combined. Because in India, in some of these cases, if this information gets combined with general health, there are significant consequences that can happen. So we wanted an architecture that would allow both of this to coexist simultaneously. So we put in a lot of effort to make that possible through a special kernel level discovery protocol, which you'll have to read about And if you have questions, we'll be happy to go into more detail in our next Saturday session.
Sure. So, Siddharth and Sid, thank you so much for that educational thing. There are other questions, but many of them pertain to business models around the health stack, and some of them talk about legal and regulatory elements of the stack, which in today's technical session, is not probably the right panel or the planning to cover. But I understand, Sharad, that you are encouraging people to continue to ask questions, and in the next section, you will try to actually respond to many of those.
Yeah, and we intend to use the same form as we go forward, so that we can combine questions and answer them more thoughtfully. We needed a place to log the questions, which was going to be persistent beyond just one Zoom session, and that's why we did not use the Zoom chat model, because then creating that persistence would have been harder. And we think actually your best questions will only come after you go through the GitHub documents and go through the source code. Then questions will come, and those are the questions that we want to encourage. And just to amplify, we will attack this whole set of questions about business models, pricing, all those will be sorted out over a period of time. But we want to do that only after we have a pool of people who have a deep understanding of the technology. Then more informed questions about business models, etc., can emerge. So, so that is the reason we are doing it.
All right. Thanks so much, Sid, and thanks so much, Sharad. With that, I think we'll put this to an end. I think we're a wee bit early, about 1:16, but thanks so much for your time, and thanks for taking all the effort to patiently explain the internals of the personal health record. Take care, everyone. Bye.